Thank you for attending this little workshop with Dr. Kaut and myself. 2 years ago I came here for the first presentation. A lot of microbiologists came to Bucharest for hearing the presentation about laboratory tests, and I want to introduce you Professor Armin Schwarzbach. Maybe you show yourself. She's the only microbiologist cooperating with us and caring for Romanian Lyme patients. And this is a start-up maybe. I hope that more doctors will assist and care for your Romanian patients. But thank you for Professor Schwarzbach to come here, and also your husband. Thank you. So I am a Lyme disease specialist, or how you will name me. I'm a laboratory specialist. I studied medical doctor also. I did therapies with patients, internal medicine, infectious diseases, cancer patients, etc. I got the director position of the International Lyme and Associated Diseases Society in USA. I was elected in October in this position, one of the directors. I'm meanwhile the international expert for the Chief Medical Officer's Clinical Advisory Committee on Lyme disease in Australia. I went to Canberra last March, and also Australia is asking now the question, could Lyme disease or Lyme-like disease exist in Australia or not? Because there's a rumor in between the Australian patients. They feel that they have Lyme disease, they have this infection, but the doctors, they say Lyme disease doesn't exist in Australia. So they will find out now if really Lyme disease exists in Australia or not. And I was in Ireland, in Dublin. I have spoken at the Health Committee of the Parliament. And in Ireland, I think it's a very open-minded country, actually. And I see some positive political signs in Ireland to care for Lyme patients seriously, that chronic Lyme exists and that it's really a problem worldwide. You heard from Lee Cohen that 300,000 new infections actually in USA, 300,000. That's a lot. In 10 years you have 3 million new infected patients. So that's a big problem. I, for myself, are working in the Borreliose Centrum in Augsburg. We have a small clinic. We have around 8 therapists in our clinic. We have patients from all over the world. We do a compact treatment with the patients, with antibiotics, with alternatives, with herbs, and we use also the herbal program from Lee Coden, because Lee established that program, and I think it's really an option for patients to improve and to get better. I want to do a short basic course with you about ticks. Ticks, you have a lot of ticks in Romania, I know, and the ticks are very little, they are very small, they have just 0.5 millimeter when they are in the stage of a larva, and you don't see them with your eyes, so that's a problem, because if it's such a small spider, you don't see the spider, you don't feel the tick bite, and then you got infected. And this is a high dark number behind that so many patients worldwide are infected by this larvae and by very small nymphs. The nymphs have just a size of 1 millimeter. You don't see them with your eye. You think it's a spot on your skin. You don't see and you don't feel them. That makes it very problematic. The dark number behind these Lyme disease infections is very, very high worldwide. If you have a very big tick, an adult tick, a very adult tick, you see it. You see your blood in it, and then you scratch it, and then you put it away. But most infections are caused by the nymphs and some part of the larvae. What's very astonishing for me or for you maybe, that a tick can survive, one tick, 9 years. 9 years is possible for one tick to survive. And what's really shocking, one tick woman has around 9,000 tick children, 9,000, just one tick. You know, the climate is changing a little bit. In Bavaria, I live in nearby Munich, we don't know snow in Bavaria, it's impossible. In east coast of USA, you had a lot of snow, you had an ice storm, but here in Bavaria it's a typical snow country, no snow. We have now tick activity in Bavaria in January, which is completely atypical for Bavaria. So with the climate something is changing, something is happening. And I think in Romania, here in Bucharest, it's atypical also for you, the climates. And the higher the temperature, the more ticks you have, also during winter time. Where does it come from? The Lyme disease. Lyme disease is a very young disease. The first case was described in the city of Lyme. It's a small village in New England, in Connecticut, and it gave the name in 1981. And if you go back in medical history, maybe you can remember that in 1981 HIV was the same time with Freddie Mercury, this story, although it exists very long HIV virus in the world, but it was detected, the first case for HIV and Lyme disease was described in 1981. So it's a very young disease. And that time, a little bit later, came the Helicobacter pylori story, So we have a lot of infections we don't know actually, maybe that's a question also for the microbiologists. So what are the reservoirs for ticks and Borrelia burgdorferi? We have a lot of mice and rats, they are all full of ticks. We have birds, we have foxes, deer, rabbits, hedgehog and snakes. Also, ticks can suck the blood from snakes. In the USA, they have the Lone Star tick, and the Lone Star tick lives from the blood of snakes. But for me, it's very important to tell you that many, many infections, the patient, they got from the domestics. If you have a dog, the dogs are full of ticks. The dogs bring the ticks into your household, and the dog is in your bed, the tick is in your bed, so you can be bitten under the Christmas tree, for example. Christmas trees can be full of ticks, and if you bring the Christmas tree into your house, the ticks, they get active in your own household, and then you got bitten in your own household, in your house, not outside. So domestics are very, very important transmission way for Borrelia burgdorferi, very important. So what are the groups of higher exposure and higher risk for Lyme disease? Everybody who is outside has a very high risk to get an infection or a tick bite. Forest officers are one of the groups, lumbermen, also hunters. We have a lot of hunters, deer hunters, they are all patients, they have many, many tick bites the whole season. Countrymen, also the wine dresser, employee in the gardening, and soldiers are a high-risk group. I had a soldier from Afghanistan and he had Lyme disease, a German soldier, and he told me the enemy was not the Afghan soldier or the bad guy there, it was the tick. His enemy, he was a 2-meter guy, a pioneer guy, and his problem was a tick bite. A big problem also for soldiers and policemen. Policemen, they are always outside. Customs officers, the children in kindergarten and schools, also teachers are high exposed to tick bites. Horsemen, horse riders, very famous horse riders, camper, fishermen, wanderers, Nordic walking, recreational athletes. Bastian Schweinsteiger has Lyme disease. Robert Enke had Lyme disease. Our former national goalkeeper is dead now by suicide. Maybe you have heard about this. Also very prominent people, actors. Michael J. Fox is suffering from Lyme disease. For example, Cassius Clay, Muhammad Ali, Ronald Reagan. So a high list of very prominent people who are very often outside, they all suffer from Lyme disease. And pet owners, I told you before. And this is also described, it's in-house infections. How to kill a tick. Do you know how to kill a tick? You need temperature over 50 centigrades. You cannot kill a tick just by your normal washing steps. You need over 50 centigrades to kill a tick. So it's very temperature resistant. This is a slide from Alan MacDonald, a friend of mine. He showed that Borrelia burgdorferi, you showed us the data about 4 subspecies, but we have more and more subspecies of Borrelia burgdorferi. One, you all know, that is the Afzeli subspecies, the Garini subspecies, and Wallaceana. These are the 4, but now we have a brand new story of Borrelia mayamotoi. This is a big problem also. So we find more and more subspecies of Borrelia burgdorferi. It's not just the 4. I think the dark number behind is also much higher. We have also subspecies Japonica for Japan. So we have a lot of subspecies. That makes it also very complicated for the diagnosis with our test systems we have. This is also very important that you find not the typical spiral heat, also for your therapies, you find also round bodies or cystic forms. So Borrelia can change immediately within 30 seconds by external influences the own structure, protection mechanism. So bacteria are very clever, they are living organisms, so they protect by cystic forms and by, or you name it, maybe pleomorphic forms. This is another description. And this is not so new, but Dr. Eva Sapi is very engaged in this to show us more and more about the biofilms. What is a biofilm? Lee, you said it's a protection or it's a slime maybe production, but it's also a communication area. So the bacteria are chatting in these biofilm structures. So if you want to destroy Borrelia or some chlamydia, some other biofilm producers, Staphylococcus klebsiella, you have to destroy the biofilm also, otherwise it doesn't function. And I was thinking also how to destroy it, and Dr. Eva Sapi, she showed us that serrapeptase from Nutramedix is one example, destroying in vitro the biofilm. So it's one of the possibilities that you can destroy biofilms, and then you can reach the bacteria to destroy the bacteria. That's one of the ways in the future. Also the Alzheimer plaques, also you have discussed this point, are Borrelia biofilms partly, and Judith Miklósi, she's very engaged in this field. She's a neuropathologist from Hungary, from Budapest, from Dr. Boksic from this group. She's very engaged in these Alzheimer plaques, that they can be partly biofilms. So we don't want to say that every Alzheimer disease patient suffering from neuroborreliose or from Lyme disease, but it belongs to the differential diagnosis to find out if this Alzheimer's disease patient could suffer from Lyme disease, because the therapy consequences are completely different than if you don't have Lyme disease. So how to find out a fresh infection? Fresh infections with Borrelia burgdorferi, you see a bull's-eye rash or a lymphocytoma, and the transmission of Borrelia can be 5 up to 7 days. Also, it's possible 7 up to 10 days, 10 weeks, that you can develop a bull's-eye rash, that you need 3 or 2 months to develop a bull's-eye rash. So it's not guaranteed that you develop a bull's-eye rash immediately after a tick bite. And that's very, very important. You have to learn it, you have to know it as a medical doctor or a diagnosing doctor. Just 30 up to 40% of Lyme patients develop a bull's-eye rash. So you cannot exclude Lyme disease not having a bull's-eye rash. 20% of the patients who got infections, they have a feverish reaction. You might say it's a summer flu, like a summer flu in summer. So, and then they have just a little bit fever, that's all. But this is a Lyme disease infection after a tick bite. If you see the tick, but you know the ticks are so little spiders you don't see them, that's the next problem. A good message for all of you, 90% statistically of the patients with this stage 1 are cured with or without antibiotics or no other therapies. They have good options. Think over it. If you all have a tick bite, you all got sick, like the whole world would be sick then. This is not the truth. So 10% got sick, but if you have 100 tick bites each year, then think of the possibility to get a chronic infection. Just 30 up to 40%, that's statistically also very significant sentence. Remember a former tick bite. So if you ask for a tick bite a patient, that's not enough to find out if it can be Lyme disease. Very important message. This is what the bull's-eye rash is looking. You see here was the tick is now away, and here is living Borrelia in the skin. This means immediately use antibiotics and control this patient. Normally you should give this patient antibiotics for 4 weeks, not shorter. If you give 10 weeks, in my eyes, absolutely too short. I see so many patients too short antibiotics, just 10 days doxycycline, that's most common, it's cheap worldwide, but there's no control of the doctors after this Bull's arrest. What's happening with the spirochete? Is it still there or is it away? What's with the patient? No control of these fresh infections worldwide, and this produces us masses of chronic infected patients. Don't forget that these erythema migrans, these Bull's arrests, can be everywhere around your body, everywhere. It's not that you have it just on one spot. It can be on a completely different place on your body. Very important. Also, children, look, here is a Bull's arrest. Look at behind the ear. The children are on the same height, like it's the tick is. It's 1 meter, something like that. And here was a tick bite. This is Bull's arrest. It's very difficult to diagnose for medical doctors. If you have a stage 2, which means acute neuroborreliosis, you see here this patient is looking like he has an apoplectic insult, but this is stage 2 of Lyme disease. But you have to think of Lyme disease. It's not so easy to think of it. It's just information and doing this job maybe daily in hospitals. In stage 2 or 3, you have acute chronic situation. In stage 2 or 3, it's more chronic. You have arthritis. You see here that was a patient of mine. The left knee was swollen a little bit in this case, but many patients, they don't have a swollen knee. It's more arthritis without any swollen knee, but you have pain in the knee. And if you have a stage 3, a chronic situation of Lyme disease, you can develop, you could look at your own hands if you want. This is acrodermatitis. But not each doctor is looking at your hands. If you go to a doctor, the doctor doesn't have the time to look at your hands and what's going on. Maybe you have acrodermatitis. Acrodermatitis is a chronic situation of Lyme disease. And if you do biopsy here, you will find living Borrelia by PCR or by culturing by other methods. That means it's proven that you have acrodermatitis. And if you treat the patients, it's reversible. That doesn't mean that you have it your whole life. We had an 89-year-old patient who got cured from acrodermatitis after 30 years of having this problem. She was not diagnosed with it. This is when a patient is coming to Dr. Kauen or to myself or to other people caring for this field, or Professor Kretu. What are the patients telling you? What's their problem? I see all of the patients coming to myself or asking me for help. All of them, they have a chronic fatigue syndrome. That's so typical for this disease. So everybody who has chronic fatigue syndrome should look for Borrelia or Lyme disease infection. Also, sensitivity problems with 81% are very often. You have tingling, ants running, numbness, needle burning, burning hands, burning feet. And in most cases, the site where the tick bite and transmission of Borrelia was is the dominant site where the problem starts. So if you have here a problem on the left elbow or the left knee, then the tick bite was on your left side surely, because Borrelia is looking for the shortest direction to make the inflammation at the beginning, but then it's moving all over the body around and you got a multisystemic problem. Shoulder pain is very often, neck pain is very often the patient's, headache, dizziness, and this migraine joint pain, also rheumatism, general weakness of the body, the cup of coffee or tea is falling out the hand, that's a typical question for patients, feverish reactions, mental strain, depression, schizophrenia, psychosis, back pain, sciatic pain symptoms, sleeplessness, very important symptom for me, also maybe Babesia symptom, the urge to urinate and the sleeplessness between 2 and 4 o'clock. So at the beginning of the infections, the patient has a very hard night sweat, and it's between 2 and 4 o'clock. You can ask the patient for it. Is it before midnight or after midnight? The patient will tell you it's after midnight, between 2 and 4 o'clock. And this sleeplessness has a next problem, that you develop more and more chronic fatigue. You don't have a good sleep. The other point is sore throat, a tendency for general infections, and then we come to the opportunistic side. Herpes infections are possible, Epstein-Barr virus infections, cytomegalovirus, CMV infections, everything is possible in a chronic Lyme disease patient. You could develop burning eyes, Also the problem of burning eyes and the blood vision is very often double vision and lightheadedness. What does that mean? You need maybe a muscle testing. If you're an expert for it, you can test it. But if a normal doctor doesn't have the experience to do it, it's a special group who can do this. But what can we do? We can ask simple questions to a patient. Do you have these symptoms or not? And the combination of the symptoms makes it very specific that you suffer from Lyme disease or not. It's a combination of the symptoms. It's not just one symptom to say you have chronic fatigue, you have Lyme disease. You have also to ask for all of the other questions. So the magic word is anamnesis. You have to ask a patient 1 hour about all symptoms. Otherwise, it's no good anamnesis, forget it. It's like if you do cancer anamnesis, something like that. You have to ask a patient all of his symptoms, the whole history of a patient. This qualifies you really, and then you learning more and more for yourself. That's very interesting, and most of the patients will tell you exactly the same stories. It's not so far away, and you can get infected during childhood, and then you control this infection, and you have some event in your life, a car accident, surgery, or some traumatic. You have something in your life, and then you got a reactivation of this. You got very, very sick, but juvenile arthritis could be a Lyme disease. During childhood was not diagnosed, was not treated, your immune system controls it. It's immune controlled, like an HIV model. HIV is also immune controlled, so you can compare it. This is a basic question for all of us, caring now more and more worldwide. Do we have really new options for patient groups? That's the big question. I say yes, because it belongs to the differential diagnosis that chronic fatigue can be also chronic Lyme disease. Also ME, multiple encephalitis, also multiple sclerosis, ALS, the amyotrophic lateral sclerosis can be also be caused by Lyme disease. Joint and muscle rheumatism, arthrosis, fibromyalgia, Parkinsonism, Michael J. Fox story, dementia, depression, autism. Big problem everywhere around the world, autism. Autism is, in most cases, I have seen a combination infection of chlamydia, mycoplasma, and Borrelia, and I think Lee Corden will tell you later about this combination also. Thyroid, you showed perfectly this picture with this inflammation of the thyroid gland. Also autoimmune Hashimoto can be caused by an infection. That we know all about this, but we have to not to look at the thyroid gland, we have to look at the whole body. The whole body is important, not just the thyroid gland. That means the whole body anamnesis. That's the key for finding out if it can be infection or not. Infertility, heart rhythm disturbances, heart attack, and stroke. It's a very easy question to ask a patient. Do you remember tick bites? Are you very often outside? That means anamnesis is very, very important to find it out. This is a slide which was shown by Professor Corden. So we have a lot of chronic fatigue. We have also studies about this. It's not just Judy McCloskey who find out that maybe this Alzheimer can be caused by Borrelia burgdorferi. So we name it a chameleon. That's a chameleon. We name it the chameleon of the symptoms. But what about our oldest patient? That's a very important question. Who is the oldest Lyme disease patient? Who knows it? Okay, it's Ötzi. So Lyme disease is a very old infection, 5,300 years old. The Iceman had a Lyme disease infection. And his genome, it was by Zink's team found out that 2/3 of his genome was the expression of Borrelia burgdorferi, a bacterium which causes Lyme disease, and Zink, the group of Zink, found no other telltale signs of Lyme disease in Ötzi's tissues, but he speculates that tattoos on the Iceman's spine and ankles and behind his right knee could have been an attempt of this Iceman to treat his chronic joint pain that occurs when the condition goes untreated. So I think he really suffered also in Austria from this Lyme disease, this very old Iceman. So it's a very old infection. Now to the Corden support protocol. We did in our hospital, it's now 3 years ago, this pilot study, which was mentioned by Lee Corden. The aim of our study was to integrate in our concept the Corden protocol in a holistic therapy concept, considering several aspects. We want to get the experience with this naturopathic protocol for ourselves. We want to observe the effectiveness of this codon protocol in comparison with our experience in our hospital, with other naturopathic concepts. Solely codon is not the only concept we have. There are also some other names in this field. We monitored the patient by the effectiveness of the protocol with a questionnaire before, during and after the treatment. So we asked the patient, what about the symptoms before treatment, during and after treatment? We monitored also by laboratory tests the protocol with the serology, that means the antibodies by immunoblot, the ELISpot test and the CD57 count test. We also did some other question. Is the lead codon protocol, is it a safe protocol? Is it sufficient protocol? Are there any effects on the co-infections? Are there any bad side effects by the protocol? What about the length of the treatment? What about the irksome reactions? You have heard about these points. The evaluation was to do a complete medical history. That's, I told you before, it's anamnesis of the patient. We asked for the risk for tick-borne disease. We asked for travel histories, social history, family history, and history of current illnesses. I developed 5 years ago, by the support of German self-help group patients, a 16 pages questionnaire. Don't laugh at it, but I think this questionnaire catches about 99.9% of all symptoms when a patient is coming to me. There's no symptom missing on this list. If you will find some symptom missing in this complexity of Lyme disease or other chronic infections, you can tell me a symptom. 16 pages anamnesis, that means 1 hour anamnesis with each patient. That's very, very important. That's the key to find out by a clinical symptomatology if Lyme disease is possible or not. But we do also, I'm a laboratory specialist, we do also traditional diagnostic tests. We do the physical examinations, heart, chest, differential diagnosis. We look at the skin, we look at the cranial nerves. We do a lot of tests. We do ECG, ultrasound, we do MRI. We look for everything in the differential diagnostic world, to exclude or not to exclude Lyme disease by all of the tests. This is now my baby. I started, it's now 8 years ago, very critical about the T cells. And now I'm a fan of the T cells. Everybody can change his profession during his job, I think so. I started believing that each infection must express just antibodies. I learned my teaching fathers and mothers, they were professors for teaching me, if you don't have antibodies for HIV or tuberculosis, you don't have it. You don't have the disease, so it's excluded. But I have learned more that in Lyme disease, it's a chameleon, we have a completely different situation. And also in tuberculosis, we have also a little bit different situation. We don't have an antibody immune response, we have more T-cellular immune responses. And nowadays I do each day 50 or 60 tests for patients worldwide with the question, is there T-cellular activity or not? This is very important for explaining you the study, what's behind this study. It's not just doing a study with 20 patients for nutramedics. There's a lot of science behind also this. Antibodies were done, you do it also here by Professor Creto, by immunoblot. We use the ural line immunoblots. You see a lot of bands. Very important is the VLSE structure. Some laboratories, they use C6 ELISA, all of the stuff. In the IgM, it's very important to find out if there's OSPC, outer surface protein C or not. Very important question. VLSE is not so old antigen. It's a synthetic antigen. It's a cloned antigen by test producers, and we name it in vivo activity associated. It's named the VLSE VMP-like sequence expression site. The problem of this antibody is, if you find an antibody, you can tell a patient, yes, you had a tick bite and Borrelia was coming into your body, but it doesn't tell you anything about activity of this disease, if it's really a high activity or low activity. From my standpoint, The higher the antibody titer, the better is the humoral immune system working in a patient. So it's not bad to produce antibodies. Also, if an HIV patient produces antibodies, it's a good sign. It's better sign in prognosis than if the antibodies is going away. It's in each infection the same. We have a very high specificity of the antibodies, so it's no wrong result, it's no false positive result, although in Australia there are some professors, they tell every time the IgM is unspecific, although the patient has absolutely typical symptoms, and this is not fitting to unspecificity of antibodies. So if you have the symptoms and the IgM antibodies are there in the body, then you have a sign for chronic infection. That's all. The sensitivity is our problem. We have very, very bad sensitivity. That means we have a lot of false negative. And all of the doctors, they believe the ELISA is the solution worldwide. But ELISAs are not standardized. ELISAs have several antigens, which the other ELISA doesn't have. It's ELISA, forget it, throw it away, 30% sensitivity. It's for me shocking that you believe ELISA diagnosis. So you can argue with me, no problem. Actually, I have a case from Vienna. The same test producer by immunoblot in my laboratory, borderline positive, IgG. In Vienna, the same test producer, Euroimmune, completely negative. Completely negative. The same serum. And we send it to the test producer, and he has a positive result. So what now? And I have written an article in the doc medium. It's named Rolling the Dice. You roll the dice. Forget it. You roll the dice. Good luck, bad luck, with antibodies or not. The same test producer. 3 different results. The same method. So, what's going on now here? Do you believe immunoblots or not? I don't believe them. So the clinic, the symptomatology is more than important in the diagnosis. And then I came to this field with this LGT test, which is also criticized very interestingly, although it's by the CDC. The CDC established it in tuberculosis. It's the gold standard in tuberculosis, this gamma interferon release assays, the lymphocyte transformation assays. These are the gold standards in USA for tuberculosis. But for chronic Lyme, it's not accepted. They say it's unspecific, although you use also antigens for Borrelia in the test. So it's incredible. It's political. Let's say it's political. These is a proof test. You use each spot you see here. I do a lot of tests for these LTT, for patients, for doctors, for everybody. You see here a lot of spots, and this patient has a T-cellular immune reaction against Borrelia burgdorferi antigen, or you can use also other antigens. And there are more and more studies coming out now, so that we are not on the wrong way. The ELISpot assay showed the specificities, a study from Sweden from 2012, 82% in neuroborreliose, which is not bad. And also another study has 100% specificity in children, but I'm very proud about that there's a good scientific, now the iSpot technique coming in USA by a new laboratory, advanced, no it's not advanced, it's neuroscience laboratories, they're working with the university together, and they have written actually reports that the sensitivity of this ELISpot is around 84% and the specificity is 94%. And the ELISpot is provide robust, high reproducible test. It can be retested for the acquisition of additional information in follow-up assays, and that you should do also the CD57 cell count together with it. CD57 cell count are the natural killer cells, and they can be suppressed in chronic bacterial infections like Borrelia or some other infections. So according to these new studies, we have a not so bad specificity and sensitivity of around 82 up to 100%. What does that mean? If you have a negative ELISpot, or it's not also excluding Lyme disease, but no laboratory test in the world can exclude a disease or can prove a disease. So you have to learn about this. Laboratory is helpful. It's worthful, it gives you information like in cancer or HIV, but it's not proving a disease. How to prove a disease, that's the next question. And this ELISpot LDT chronic borreliosis, if you see it here, these are several patients we treated, and you can use it before and after treatment. Before treatment, if the ELISpot is very high, the actual T-cell activity, after treatment should be low negative. Then you have reached the aim and the patient is maybe cured, or the life quality is better, or maybe has some other problems, but some other reasons, genetics, environmental medicine, etc., etc. The CD57 cell count is part of the natural killer cells, and the CD57 cells are very important for the cytokine storm. It's a summarizing of the cytokine, the interleukins, TNF-alpha, interleukin 1, 2, 6, 10. These are the main interleukins, and if you have pain, you have a very low CD57 count. And CD57 count, very important. If you have 1 year infection, it's going down. So if I do it for you, and you ask me, I have a patient here, I would tell you, Dr. Schwarzbach will tell you its CD57 count is low. This patient must have Lyme disease longer than 1 year, and it's nearly, if the predictive value is not bad, I think in 99% this patient is sick longer than 1 year. So it's a sign for a chronic inflammation process. The next question, is it just specific for Lyme disease? I say no. I see a lot of low CD57 count in chlamydia infections or mycoplasma infections. So it's a summarizing situation, but we don't have scientific studies. Actually, I will do some studies, but you will see that what's coming out there. So the chameleon of symptoms and laboratory tests, but what about these co-infection? And Leo did a perfect job. We have a lot of co-infections. We speak about the dirty needle. The tick is a dirty needle sticking into your body. Dirty needle full of other bacteria and maybe viruses. Not everything is known. The European Union spent 4 million euro for a project in Europe to look what's inside the ticks. We are not sure, or the mosquitoes, we are not sure which bacteria. We have now better PCRs to find it out by new primers, which bacteria or which new bacteria. I'm not convinced that we know everything about each bacteria in these vector-borne diseases. But we know actually that we have a lot of problems with Babesia, Bartonella, Ehrlichia anaplasma, chlamydia, my favorite, Rickettsia, Coxiella, mycoplasma, and viruses. This is a complexity of a multi-systemic disorder, and the reason is a multi-infection syndrome, like you described it also, and Dr. Horowitz in his newest book also described the situation. Just a short time to my favorite, because you will see that worldwide problem number one is not Borrelia, problem number one is chlamydia pneumonia infections. In Australia they know about that problem. Why? Because the koalas and horses and frogs, the veterinarians, you showed it also, Lee, perfect slide, that the veterinarians, they accept more chronic infections than the human doctors. You saw the numbers in America that so many dogs are chronically ill but not humans. That cannot be. And in Australia, the veterinarians, they have hospitals for koalas. Why? Because the koalas had bad chlamydia pneumonia infections, and the koalas have a chronic fatigue syndrome. You know all the koalas lying on the trees? They are also sick. And if a park ranger got sick by Borrelia question or chlamydia, it's not accepted. The koala has a hospital, and the koala got antibiotics, but not the park ranger working in Australia. That's policy, or I cannot explain it by myself, but it's a very strange situation. It's a sarcasm behind somehow, but we cannot understand it. The veterinarians are one step in front of us, absolutely. To speak with veterinarians, there's no problem to say, oh, we have a chronic dog with Babesia or Ehrlichia, Rickettsia, but if you speak with a human doctor, no, it doesn't exist, chronic, no cases described, we don't have it here, nobody's caring for this field, it's absolutely excluded. That's a big problem. What about the symptoms? The chlamydia symptoms are nearly the same when you have a chronic infection like Borrelia symptoms. So it's very difficult for you to say it's chlamydia, is it Borrelia, or is it both, or what is it? Alzheimer's disease, and Judith McGloshy also found out chlamydia in Alzheimer's disease patients also, and multiple sclerosis patients, very important. Many of the multiple sclerosis patients, they have a chlamydia problem also. They have a Borrelia problem and a chlamydia problem, or they have no Borrelia problem, but they have a chlamydia problem or mycoplasma problem. Chlamydia is number one worldwide, what I see by my results, absolutely. And it's not just here, it's all around. Why? Because it's an aerogen transmitted, it's by cough, and the transmission is very, very high. You're sitting here and you're coughing into the neck of your neighbor, and he got this atypical pneumonia in the train, on the plane, and then you got infected, and then you have it. There are some studies that people over 60 years, nearly 100% in Germany, had or have this infection. And the association is exactly the same as you look at the Borreliose story, exactly the same for me. So I came to this point, and it was very interesting to look by test is it the truth or not. Now we rove a little bit more for the solution. The solution, nobody can remember, if you learn infectious diseases, about all of the infections, you cannot remember in your brain which symptom is coming from rickettsia or babesia, what's the Bartonella, maybe Lee can do it, or muscle testing, something like that, but I cannot remember all the symptoms. It's not possible for all of the co-infections. Also, Professor Preto has to look into her book, teaching book, is it possible this symptom and this infection? And if you look into the books, the description of the symptom is completely different. You have to find a consensus. Why? Because these institutes caring for chlamydia or rickettsia, they're just looking for chlamydia or rickettsia. This institute, this university is not looking for multiple infections. There's no study looking for multiple infections worldwide. No studies, no study design. They all look just for one bacteria. But we know that it's a multiple problem of several bacteria because it's dirty needle. That's all to say in this case, dirty needle. So we have developed, there for this purpose, a co-infection checklist. We will digitalize it worldwide for patients or doctors to fill it out. It's a help tool, a helping tool. So the patient has to fill out such a co-infection checklist, and you could do it also, and you will see that I'm on the right side of what I'm doing. You see here the symptoms which are described in scientific books for the co-infections or some other infections. Also Yersinia infection is very often, Salmonella infections, Coxsackie virus, enterovirus infections, EBV, CMV, or also protozoal infections. We have a lot of infections, but we live with the bacteria, but not everybody got sick. And then we developed this ranking tool for medical doctors. It's not for patients to be used. And by this I want to show you that this Coden support protocol is really helpful in this co-infections problem also. You see, the Coden support protocol, if you go into the deep of this, Samento is very, very helpful for the TH1 system. Also Comanda, also Quina, Takuna is very helpful, Noni, Banderol, Barberry. A lot of these products are very helpful. Melatonin also. Interestingly, the melatonin deficiency is during night 2 and 4 o'clock. That's very interesting to see. And if you give a patient melatonin, then the sleeplessness is much better, and I think Lee can tell us also how to go against this sleeplessness by some products. DHEA and selene and zinc, magnesium. So now to our study. We did 20 patients. They were treated continuously for 9 months. Protocol cannot work within 2 days. That's nearly impossible. The Herxheimer reactions, they are mostly coming the first week, the second week, and the third week. This is the climax of Herxheimer reactions. You will see in many, many patients when you start to treat them. But this is independent if you use antibiotics or if you use herbs. That's no difference. The Herxheimer is coming, and if Herxheimer is coming, it's a perfect situation. It's perfect. That means something happened, something works. And the patient is telling you, oh doctor, my left knee is hurting. It never hurts. Oh, that's perfect, your knee is hurting. I have the problem with the right knee. I had it before the right knee, but now it's my left knee. I said, perfect working. No, you're telling nonsense, it's not working, it's bad for me. No, I say, it's a perfect situation, it helps you, you will reach your aim. The Borrelia has destroyed the other bacteria. It's hidden, it's in the tendons and everywhere, intracellular hidden. You can ask each patient this, and then you will improve. You will improve. If Herxheimer is very, very helpful. Okay, you want to improve 100%, if you improve 70%, it's also improvement of life quality, or 80%. The patient wants to get to 100%. We come later how to reach 100%. Antibiotics cannot reach in every case 100%. And if a damage is there, you cannot repair the damage. If the tendons are destroyed, you cannot repair the tendons by any therapy. And maybe you have to live with it, or maybe you have to do some surgery with it. But don't do a surgery without protection. Don't do just a surgery, you spread the bacteria everywhere around. One of my friends is Dr. Armin Schwarzbach. He's a very famous hand surgeon in Klagenfurt, in Carinthia, and he sent now, you know, the Dupuytren's contracture, this of the tendons here, hand surgery. Dupuytren, it's a bad contracture, your fingers are going there, and he sent biopsy during his surgery to Professor Selger in Innsbruck, and they have proven the first cases that Borrelia burgdorferi is in this operation field. The question is now, that's a revolution for the whole hand surgery, or this is when it will be published, what will be highly discussed. So that means before you do surgery, you have to look for Lyme disease if it's not the reason for your hand problems, for your tendon problems. And if you have the tendon problems, you don't do surgery first, you do an antibiotic or some other therapies first. That's normal medicine we are doing, but you have to look at the differential diagnosis. So, what about this study now? We had 7 male patients and 13 female patients in this study. The age was 15 up to 53 years. The median of years was 39.3 years. And all patients were diagnosed with chronic Lyme borreliosis, chronic Lyme disease, confirmed also by laboratory testing, by antibodies, and also by LTT test, and so on. All patients had co-infections. This is a very important point. I never saw any, for me, just Lyme disease doesn't exist. They all have co-infections. They all have other problems. Or maybe they have environmental problems. They have genetic problems. They have a lot of problems. But just Lyme disease doesn't exist. We have multiple problems. And we see it by the laboratory results. The more you look, the more you find. All patients had co-infections. 15 of these 20 had chlamydia pneumonia infections, active infections. We do this by the IgA production. We find the IgA persistence over years, and we do this LTT and was high reactive. Mycoplasma pneumonia, the same, we do IgA for it, it was also active. And anaplasma, also Ehrlichia, 7 patients, Bartonella, it's a big problem, Bartonella, Henselae, and some Quintana we find by antibodies, Yersinia, very important, Toxoplasma. Additionally, some of the patients, they had also EBV, herpes-wise, because the immune system is breaking down then and herpes is coming out. Or they have Coxsackie virus. I think Coxsackie virus, we underestimate enterovirus somehow worldwide. We see it, I think, you also by the IgA production, by the IFT. The IgM is not important for us. For chronic questions, we are looking for the IgA antibodies, not the IgM. You have to learn it. If you learn at universities, in chronic infections, you don't look for the IgM. Maybe you do a control of the titer for reactivation, but it's not our question. We want to look for local standing antibody production, IgA, because it has a half-life time, IgA 2 weeks, something like that. The persistence of IgA level. So the antibodies are moving more to the IgA, and I think Professor Cretu can, she's also clapping her hand, that's the right word for all of us, for the microbiologists also. So what about the study? All patients had been treated with antibiotics. All patients had been treated. Besides, we did this serological testing, the ELISpot test and CD57 counts. In addition, we did regular checks of blood count and liver and kidney parameters. If you do any therapy, you should control the organ system. It's very easy and cheap to do some liver enzymes, kidney enzymes, if everything's fine with the organ system. That should be done normally. All patients had to fill out the questionnaire about the health status every 3 months. It's a long-term study. 2 of the patients, they had to stop from the 20, that means 10%, they had to stop the treatment, the Corden protocol. Why? One female patient, aged 50 years, because she developed a cancer. Then the question arises, can cancer also be caused by some infections? One female patient with 15 years developed acute psychosis and was not able to take it any longer. But you see there was no side effect of the protocol that the patient had to stop it because of a side effect. The tolerance was very good for 5 patients, and 10 patients told us it's a good tolerance of the Nicodin protocol. Some side effects for patients, but these were bad tolerance to Pumanda and to Tunia, but we will tell you something how to go over this point. And severe side effects was just 1 patient with gastrointestinal side effects. So 75% of the patients from this very small study had very good tolerance to the protocol. It was no problem. The question is also the outcome of such a protocol. 80% of the patients showed improvements. I don't want to discuss if a patient is healed or something like that. Nobody can guarantee you a healing till you're getting 100 years or something like that. But in your time frame we are living, we say it's improvement. The life quality is very important in evidence-based studies as a criteria. If you improve by this, then you have reached your aim by this therapy. And 90% of this, 80% we can document by laboratory tests. I will show you later. 10% had significant improvements, 50% moderate improvements, corresponding to 6% of laboratory tests results. 20% had mild improvements. 20% of the patients failed, including the 2 who had stopped. And 45%, that's very important that this protocol also works. Nearly each second patient developed Herxheimer-like, or Herxheimer, we say not like typical Herxheimer because this is described in syphilis, but we had this Herxheimer-like reactions of the patient. So it's working, this protocol. Otherwise, they will say it's like water, nothing happened with me, and they cannot be simulants. This was one co-infection checklist of a patient we did before treatment. This patient had a lack of concentration, memory problems, forgetfulness, short-term memory problems, painful joints, general aches and pain, heart problems, a cough, headache, muscle pain, shivering, and a blood vision. This patient had 8 symptoms for chlamydia pneumonia on position 1, then 7 symptoms. Position 2 was mycoplasma with 7 symptoms. Position 3, the symptomatology was Ehrlichia anaplasma with 6 symptoms on the list, and Epstein-Barr virus also with 6 symptoms, and chlamydia trachomatis very late in this ranking. This is just to show you how we work standardized, how we try to work standardized with such checklists, because if you ask the patient, you cannot standardize all your questions. That's not possible. So you need also for scientific studies this standardized checklist. The results after 9 months, 80% improved, like I told you before. And this is now a laboratory test result of patient 1. This I have shown you before. On the right side you see the results before treatment. It's difficult for you to see it from far, but you can get this data also. It's no problem for me to copy it. But this patient started with a natural killer cell level of 147 per microliter before treatment. And this patient developed within 6 months a double high level of natural killer cells, his natural immune response, 229, that means it's nearly a doubling of that. And you see in this, the Borrelia activity in the fully antigen was 7 before treatment, and after treatment was 0. So this works also, this corresponds to the symptomatology, to the life quality. Life quality improves, symptoms, they go away, and the laboratory tests show that, exactly that the patient is feeling much better. But this patient had also activity before treatment for chlamydia pneumonia. It was 7. Its by reference range is lower than 2 stimulation indices, and this patient has threefold higher actual activity, and after treatment it was 0 for chlamydia pneumoniae. Also for chlamydia trachomatis it was 8 before treatment, according to this symptom checklist, co-infection checklist, and it was 0 after treatment, also for Ehrlichia. So the protocol is absolutely working by standardized scientific tests. For me, doing the test, it's independent where the test is coming from. I'm just doing the test. Also, Infected Lab is certified. We have an international certification for all of the tests by Professor Sack from the University Leipzig, and the German certification, the official. So this is realism, and the whole tests are certified. So no discussion about positive controls, negative controls, standards. Very, very good correlation to the symptoms. This was patient 2. Patient 2 had 87 were the natural killer cells before treatment, and after treatment he had 215. So perfect development by the protocol for the natural killer cells. It took away the inflammation process, the cytokine level slower and lower and lower, and the patient feel much better. This patient had no antibodies by the ELISA. If you do ELISA, you would exclude this patient. You would say no Lyme disease, no possibility, but the Borrelia LTT was high. It was 3, not so high, but it developed to borderline result after treatment. So I think you have to do a little bit longer therapy with this patient, because it was a very weak activity after the end of treatment. It was maybe a little bit too short. Chlamydia also, it was persistent infection. I think we can discuss it later, or you can tell us maybe some good options how to treat chlamydia intracellular infections, because all infections we speak about without Borrelia are intracellular. We're not speaking about extracellular infections. Borrelia, you have good luck, is also extracellular, but all of the infections, chlamydia, mycoplasma, Rickettsia, babesia, they are all intracellular. And then it's, I think, problematic also how to defeat or come into the cells and destroy all these cystic forms. Also chlamydia can do cystic forms, pleomorphic forms, aberrant forms. It can produce slime biofilms, the same story with the chlamydia. So how to reach the chlamydia? This is for me a central question, and therapists can answer this. This is another patient with a chlamydia activity and Borrelia activity. So you see that by these results it's really good working by actual cases. Okay, these are case reports. If you want to prove it, you need really big studies about this. The problem is the ethical committees, they don't allow such studies. It's very difficult in Germany to get the approval of the ethical committees to do any studies in this field, because they say it's a strong regulation, you need $100,000 for it, and it's nearly impossible to do studies in Germany more and more. The regulation is too strong, so maybe some other countries can do more studies about it. That was a patient with a Coxsackie virus infection also. The titer was 1 to 10 in the IgM also. And Borrelia infection, and the chlamydia was very high. It was 41, the activity before treatment, and it was just borderline, very weak after treatment. So a direct effect on chlamydia infection also in this case, shown by laboratory. Patient number 5 had an Ehrlichia, an anaplasma titer. Here you see it was not so high, 1 to 65 by the first titer step. CD57 count stayed low. Question, maybe it's not solved by the protocol in this short time of 9 months. Maybe need a little bit longer therapy. But the activity for Borrelia fully antigen was 0. So you had an effect of this protocol on the Borrelia activity, but not on the chlamydia activity. This was still borderline. The correlation of the modern laboratory tests for Borrelia and chlamydia is shown in this slide, and what I see, it's a very high correlation of the IgA, the LTT. That was the summary of this data. I did it with some other patients, with 50 other patients. We had sensitivity for chlamydia IgA was 60%, for IgG also 60%, for the LTT around 70%. If we do all three tests together, we had 80%. For Borrelia, we reach around 90% sensitivity by doing all the tests. It depends also which therapy you get. If you use corticosteroids in therapies, it's not so good for the LTT test or for natural killer cells. You suppress the immune system. I know many of the patients, they got corticosteroids, immune suppression. That's the worst situation for the immune system. You have it temporarily at the beginning, it helps. That's my experience at the beginning. But chronically, you got a damage, because if you use corticosteroids in chronic bacterial infections, that's contraindication. That doesn't make sense. So, the most improved symptoms by the Coden support protocol: the chronic fatigue improved, the chronic pain syndrome improved, joint and muscle pain improved, chest pain improved, headache improved by these patients, neuropathic pain improved, fever, chills improved, the night sweat improved, sleep disorders improved, anxiety improved, and muscle twitching also improved. The conclusions now of this protocol we had in our clinic, it was a small group, but I know also from some of my friends that it was very, very helpful also for whole families. The core protocol seems to be efficient and successful. Overall, it's a safe and tolerable protocol for patients. Both patients who stopped within our small study did not so because of the protocol, but to other reasons, very important. The main side effects included nausea, abdominal pain, and mild diarrhea. And all patients with side effects, they reacted well to a reducing of the dosage, Commander and Tutunia. 9 patients, that means nearly each second patient, I told you before, showed Herxheimer reactions, which were effectively treated with recombinations. That's to say, we have here also powerful anti-Herxheimer medicine remedies, Berber or parsley pinella. It helps really against Herxheimer reactions to reduce the pain. It's a very good option. Only 2 patients were completely symptom-free after 9 months. Treatment, completely symptom-free. The question is also, are you healed then? I cannot answer you what's now going on with them. But they had significant improvement, and it was worth to do this therapy. Otherwise, what's happening in other cases, the antibiotic regime, we had to stop it. Antibiotics were off for this patient, so we had to look for alternative pathways also. And I think the Lee-Coden protocol is really a very interesting alternative therapy for patients. Nevertheless, don't forget we have also the antibiotic way, although you don't hear it so. Lee is not a fan of antibiotics, but I know also patients, they got much better by antibiotics. But if you want to do a step more, or a patient cannot tolerate antibiotics. We have a lot of patients, they don't want antibiotics. So what to do with them? You cannot send them away. You need alternative pathways, and Lee-Coden protocol is a good protocol. And I also recommend it. I say it's one of the options for patients. Why not? We have a lot of options, and Lee showed you before the Rife machine or some other. We have a lot of possibilities, but Lee-Coden protocol is one of the options for patients. And what in this study also the laboratory tests confirmed the results. It was very interesting. The increase of the CD57 cells was shown, and the decrease of the actual activity of Borrelia illispot, as well as for co-infections for chlamydia. In this small group, overall, a good effectiveness against the most common co-infections was seen. The effects on intracellular pathogens, Bartonella, Babesia, which are very often in the red blood cells, seems to be limited. That's exactly the question you have to answer later for us, and should be tested with a larger study group. The effects and tolerability of the Coden protocol combined with an antibiotic treatment does not have a contraindication. There's very few contraindication or no contraindication to use it. Otherwise, you have an allergy against some products, maybe. But that could be also caused by Borrelia or by some bacteria. And it's very well tolerated. It showed positive synergistic effects in the patient's group. Another conclusion, I told you before, we have multiple chronic infections by Borrelia, chlamydia, and some other bacteria and viruses. They are all intracellular, they have pleomorphic forms, they have the biofilm problem, and these should be aimed by therapy concepts. Also for me, it's very interesting. Maybe one idea for you, because I'm asking what about a patient with biofilms. You have a chlamydia infection with biofilm, a lot of slime production coming out the mouth and sinusitis. Maybe we could use serrapeptase additionally to the antibiotics. That's for me, why not? That's no contraindication to try to fight against the biofilms. Otherwise, antibiotics is not working. That must be one point we can discuss also later. The naturopathic treatment protocols are very good, for me, very good alternative in treating Lyme disease and other tick-borne disease or other infections. Chlamydia is now traditionally tick-borne, vector-borne, it's aerogen transmitted, so it's also helpful in other infections and multiple infections. If an antibiotic classical treatment cannot be done to various reasons, so you need alternatives for the patients, you cannot leave them and damage them, you have to do something with the patient as a doctor. The treatment is usually tolerated well by patient, has very few side effects. Naturopathic treatments have shown almost similar results to a 6 months antibiotic treatment in our clinic. But we use also in our clinic antibiotics longer time. You have to know about this. We are IELTS group. We are working according to IELTS guidelines, not IDSA, because we know that too short treatment is just knocking on the bacteria but not destroying them completely, because Borrelia can hide intracellular and all the stuff. We know about this. And thank you very much for your attention. Maybe I answer you some questions, but not to the field of therapies. This will be done by Lee Cohen later. Some questions from your side? Okay, then we can discuss also individually. I go a short time outside, then you can come and ask me if you have some questions you don't want to ask here in the whole group, because I know some of them you have individual questions, personal questions. Huh?
Yeah, the bashful people. Where'd Peter go? Is your bladder too full? You have to take a break? No?
So, do you have many Romanian patients? Because doctors in Romania all says that chronic Lyme doesn't exist and we don't have Borrelia here.
In Augsburg, we have a lot of Romanian patients. More and more are coming from Romania because your doctors, they say it doesn't exist, but the patients have it. If we do the anamnesis, the questionnaire, we find out that they have, by the symptomatology and the history and the differential diagnosis, that they suffer from chronic Lyme disease. So, and they got infected in Romania and nowhere else. That's proven.
What are the difference between Codon protocols and Augsburg herbal protocols? Because from what I know, there are two different kind of protocols.
Yeah, we have several protocols worldwide. It's not just Augsburg or Codon. We have also the Buna protocol or the Marshall protocol or the Klinghardt protocol. So we have, I think, 7 or 8 protocols worldwide. The difference between Augsburg and Lycaonen is from Southern America herbs, and the Augsburg protocol is from European herbs. That's a little bit different. Huh? So the protocol within is not the same. The units are not the same. The plants are not the same. The herbs are not the same. You know, that's a difference.
It is necessary to use the long-term antibiotics because some voices argue that long-term antibiotics can destroy the intestinal flora.
Absolutely. Long-term antibiotics you have also a risk for a patient. I'm not the fan of giving antibiotics for years or without any control of anything. You have to look at the risk-benefit ratio. And very important is which bacteria you want to destroy with the antibiotics. So if you choose the wrong antibiotics, maybe for Borrelia and you have rickettsia or mycoplasma infection, that can damage your flora without any reason because you have used the wrong protocol. By my experience, that's a discussion about the Clostridium difficile infection and colitis. We had this also the problem with long-term antibiotics. We used it at the beginning with ceftriaxone, rosofin, for 2 or 3 months, and some of the patients developed this Clostridium difficile bad infection. The flora was destroyed, and then we changed to the concept that we substitute the flora with probiotics. And since we used this probiotics, there was no single case, thousands of patients, nobody had any diarrhea, no problem.
So it can be said that it is safe to use.
Absolutely. If it depends on the circumstances. You have to control the organ system, ECG, liver, kidney, that nothing happened with it. That's no damage for the liver and the kidney. And you have to also to use probiotics, high dosed. It's not to eat some milk, drink some milk or some milk product, eat some milk products. You have to use the capsules, high dose capsules to refresh the flora. You destroy to go at the beginning against the dysbiose, and then it's no problem for the intestine.
How do you treat the viral infection?
Yes, viral infections, it's very difficult field. If you have a combination of a bacterial infection plus viral infection, you have to destroy the bacterial infection first, and then because this is more opportunistic, the viral infection. If the immune system is suppressed, you know it. Maybe if you have a bad immune system, you develop some herpes on your lips. That's many people without Lyme disease, you know it. So if you improve the immune system and you take off the bacterial load, you destroy the bacteria, then you improve also secondary by your virus system. Nevertheless, we have also patients, they don't have Lyme, they have just the virus infections, and we cannot use antibiotics. It's contraindicated if you have Epstein-Barr with swollen lymph nodes, but you have to work it out before by laboratory help, by antibodies, by LTT tests. If you have a virus infections, you think of virostatics. This is a medicine very hard defeating or lowering the concentration of virus. But we had one patient from the charity in Berlin. It's very liver toxic, this virostatic therapy. I think the best way to go against this virus is defeat the bacteria, bring them away. Maybe then you can use some herbal programs and improve the immune system. To improve the natural immune system. That's so helpful.
Another question, autoimmunity and Lyme.
Oh, very good, very good.
Are you recommending the use
Very
of corticotherapy or immunosuppressive
very good question. I forgot to tell you during my presentation, autoimmunity. We know by literature and also by own experience, our own data, we see a lot of data that patients with chronic Borrelia, chlamydia, some other infections can develop a secondary autoimmune disorder that depends, Borrelia for example, on the mimicry effect, the antigenity, which is similar to your own immune system, and then it leads to a self-production of auto-antibodies against your cells by yourself. At the beginning, my impression when I speak with patients, I diagnosed now 20,000 patients the last 7 years, or over 20,000, I think it's now 22,000 samples I got from all over the world. What I see, a high correlation of ANA titer, anti-nuclear antibodies, and rheumatoid arthritis antibodies. That means in Germany we do the CCP antibodies, in other countries just the rheuma factor is used, the insensitive and unspecific test. But what we see in some patients that it's reversible. If you treat the infection successfully and the patients feel better, you have a chance to get rid of the autoimmune disorder also, and the titer is lower and lower if you treat by antibiotics. So the solution is not to use the corticosteroids because they suppress your natural immune system. You have to support and to bring but this depends on the complexity. You have to find out, is it really a chronic infection or not, and then you have to decide which therapy you have to use, not just giving corticosteroids. That's absolutely nonsense.
And And this is also the case for neuroborreliosis.
Neuroborreliosis.
And also for multiple sclerosis.
We know that in multiple sclerosis are also autoimmune disorders possible. The reason for multiple sclerosis is not known yet. I don't want to say that each patient with multiple sclerosis has Lyme or chlamydia infection. I see a high correlation with the group which I'm looking by my laboratory test. They have a high titer for chlamydia and Borrelia, high activity against in multiple sclerosis, in Alzheimer's disease. But this is a pre-selected group. This is a group who has also some other joint problems. This is not the only chronic fatigue syndrome. That is not the only thing the patients coming with this multiple sclerosis. They have a lot of symptoms coming maybe after tick bite or remember tick bite, or some doctors found them some antibodies for Borrelia. It's very strange for them. But the solution or the explanation for multiple sclerosis, I think you should say it's Lyme disease or co-infections. They belong to the differential diagnosis in these patients. And also autoimmune disorders.
Can you offer me more details about the new test that you are working on, the chip test, the microchip test?
Yeah, the European Union, it's now 3 years ago. We found together a Finnish university, Professor Gilbert from Jyväskylä University. She phoned me, she called me, not knowing about myself what I'm doing, but she heard about me that I care for Lyme disease patients, and by my laboratory she phoned me if I'm satisfied with my laboratory test, and I told her no. And then we tried to get a foundation for a smaller project from the European Union. And the project started now 2.5 years ago, and the aim was to improve from the European Union. They know about the problem with Lyme disease, that it exists in the whole European Union. So the chronic situation, not the actual. They want to improve the sensitivity of the Borrelia test for the antibodies, the IgG and IgM antibodies, and the aim was is to produce a cheap possibility and a possibility for the future. And this means biochip technology in their eyes and our eyes a little bit. Nevertheless, biochip technology is a very complicated technology. There's another project for HIV biochip technology, also a project in France. And we did this project, and it was successfully, it ranked position 4 among 200 projects in the whole European Union by the qualification of the referees. So it was one of the most successful projects we had, and they spent 1.2 million euros for 4 scientific partners in this project.
I read on the website that this test can distinguish between recent infection, chronic infection, and autoimmunity. What does
that was not the original aim. The aim was to fill this lack of insensitivity of ELISA and immunoblot system, and therefore the first aim of this project, it's all on the website of the European Union, but not the detailed information because it's protected by patents and so on, to develop new antigens. And new antigens are developed, and I did some internal studies with now 4 patients also, and it was 100% sensitivity. So because the first problem is if a doctor doesn't find antibodies, then Lyme disease is excluded by this doctor. They believe in this ELISA that they exclude Lyme disease. That's our main problem, to exclude Lyme disease because you don't have a positive ELISA result, And that was the aim of the High-Sense project, to fill this lack of sensitivity. And the second step is, you're correct, to find some correlation with the activity of the disease. Mm-hmm.
And when will be ready?
Yeah, the antigens are ready. The antigens are ready. The question is how to commercialize new antigens. Studies coming out this year from the Finnish University to put a patent on the new antigens, the combination. It's, in my eyes, 100% sensitive. You will find all the antibodies we want. That's perfect. We have 40% more sensitivity, which will help for screening the patient. The activity question is on another table. It's difficult to say it's an active infection or not. Therefore, we do this LTT test, and LTT test also interesting. There's a development by the test producers to find out is it an active T cell or a memory T cell. That's also where we can get some help for tuberculosis, for transplanted patients. They are working on this, and we'll test it in a few weeks in my laboratory. The first test about activity of T cells or not activity. We can correlate with our patients coming to our hospital.
Thank you, that was all.
Okay, now you can ask me more.